welcome everybody and are very grateful to both Molly and Natalie for taking the time today to come here and present and also allow room for questions and feedback too. So feel free to put questions as they come up in the chat, or at the end, we'll also have a couple of minutes for that as well. But this way, if we don't get to the question, we will get to it via the chat and then respond separately. Thank you all. And I'm going to turn it over to you. Molly, are you going to be presenting first?
We're actually going to have Natalie go first.
Okay, so I'll turn it over to you, Natalie,
Yeah.
so you can introduce yourself.
Perfect. All right, so I'll introduce myself and then I'll share my all my slides. But my name is Natalie Turner. I'm one of the social workers at the Center of Excellence for Alzheimer's Disease at Albany Med, and we'll get into exactly what that is with my piece of the presentation. All right, so everyone can see that okay so far?
Yeah.
Perfect. Okay. So just to give a little bit of background, in 2015, the New York State provided a $25 million investment, the first investment of its kind, to really look at Alzheimer's disease and dementia throughout the state. And these centers of excellence for Alzheimer's disease were created as part of that caregiver support initiative. There were 4 pieces of that initiative. The Alzheimer's Association, like Molly, is one part with ALZCAP. You have the caregiver support initiatives throughout New York State, the underserved piece of this program, and then the Centers of Excellence for Alzheimer's Disease is the 4th part of the caregiver support initiative. We're really focused on the clinical diagnostic piece of Alzheimer's disease and other dementias because we are a network of medical centers and teaching hospitals throughout the state. So we've been recognized nationally and by New York State as experts in the field of the diagnosis and care of Alzheimer's disease and other dementias. So the map that you guys see, I think on your right, shows where all of these CADs are. So the purple that I've circled, that is where the Albany Med CAD, or Center of Excellence for Alzheimer's Disease, is located. We cover a 10-county catchment area. That's circled right there. Every county in New York State is covered by the Caregiver Support Initiative overall, but is also covered by a Center of Excellence for Alzheimer's Disease. So we're located throughout the state. To give a little more information about us and our team, we were designated as one of the Centers of Excellence for Alzheimer's Disease in 2016. We have an interdisciplinary and comprehensive medical services provided to the patients of our clinic. We provide coordinated treatment and care management for individuals living with Alzheimer's disease and other dementias. We provide assistance to providers, practitioners, and other community care partners in their diagnosis and management of their patients with Alzheimer's disease and dementia, and really seek to be a regional resource for Alzheimer's disease and other dementias for healthcare staff, patients, families, anyone going through this disease, much like the Alzheimer's Association. So this is a picture of our team. At this point, it's a little bit outdated, but just so you guys can see some of the members, we've got social workers, an RN, neurologists, of course, and that's what we'll go into next, what our team looks like and how our center functions on the day-to-day, just so you guys are a little bit more aware of our services and what kind of all of this on the slide means practically for the patients, families that you guys serve each and every day. So I always like to describe our center under 2 parts. I'll go over both parts today. On the one hand, we are a neurology clinic. We're a specialty outpatient neurology clinic. So we are not within the hospital of Albany Med. We're not inpatient. We are entirely outpatient. So we have folks come in to be diagnosed, assessed, monitored with memory loss. My providers are really excellent and have the training and expertise in identifying dementia, teasing out different types of dementia, what stage is the person in, and so forth. And we really do, some of our providers say we follow our folks really from diagnosis until death in some cases, which can be 8, 10, 12 years, depending on how the disease progresses. So we really follow families through their whole progression. So our patients are seen by, of course, the neurologists. At this point in our center, we don't have a mid-level provider like a PA or an NP at this point. In the past we have, and in the future we hope to as well, just because then we can get people in a little bit quicker. But right now we have 3 neurologists on staff. again, who are all trained in the diagnosis of Alzheimer's disease and other dementias. And one of our neurology providers also has a dual specialty in both dementias and movement disorders. So she sees a lot of people with like Lewy body dementia, Parkinson's disease, and things like that. So we have the neurologists, we have an RN, and then we have 3.5 social workers on the team as well. So like I said, very multidisciplinary. We try to make it so that at as many new patient visits as possible, we used to say all, but now logistically it just doesn't always work. New patients are seen by a nurse and a social worker so that we have that contact with the families right from the get-go in case they need services or need resource connection, like to Healthy Capital District Initiative, the Alzheimer's Association, Catholic Charities, anything like that. So we like to have that contact right from the get-go. In our clinic, every patient is required to bring an informant. That could be a family member, a caregiver, someone who knows them really well. Maybe sometimes it's a friend, sometimes it's a caseworker who's been working with them for years and years, someone who can really speak to the changes that they've noticed going on in the patient. Because we're talking about memory and cognition changes, sometimes our patients are aware of the changes that are going on cognitively and with memory. Sometimes they're aware, but not to the degree that an outside informant is letting us know that it's happening. And sometimes they don't have insight at all. So it's very important for us to have that informant there to really get a good history so we can complete our comprehensive exams. And what we really look for is dementia is a disease of exemption, meaning we want to rule out everything else first. So I should say, I don't think it's clearly listed on the slide, so I'll say it now, but to schedule an appointment with us, it really is important that we get a referral from the primary care provider or another provider who knows the patient really well, because then we can look and see what has the primary care provider done. Are there labs that have been done, blood tests? Have they ruled out thyroid issues? Just other diagnoses. We had one woman come in and I think we ended up, somehow our neurologist diagnosed her with like a liver issue, just something was going horribly wrong in the body that ended up messing with her cognitively as well, but it wasn't a dementia. So again, the hope is that the primary care can rule all of that stuff out first. And we say, okay, we've taken care of the thyroid, it's not this, it's not depression, we think something else is going on. We're going to send you along to neurology in the memory center. So again, that's where my docs are really good at teasing all of that apart. If maybe the case is a little more complicated or if it hasn't been done so by the primary care. And then for every new visit, we do try to take a very thorough and comprehensive history. The new patient visits are technically slotted for an hour, but oftentimes we're spending upwards to an hour and a half just between the history gathering, the cognitive testing, and then the neurologist coming in, doing their own physical assessment, asking any additional questions to the history, and hopefully coming up with the diagnosis. So we gather quite a bit of information. We ask both the patient and the informant. It is important, what does the patient think is going on? What are they aware of, if any cognitive changes at all? And then what is the informant seeing as well? So we really ask, what kind of symptoms are you noticing? Are you having difficulty with your memory? Is it mainly short-term, long-term? Even what else is going on in life? Are there other life stressors that could be contributing to memory loss, to you just feeling overwhelmed and kind of being unable to handle the day-to-day? How are you managing your meds, your finances, the cooking, the cleaning? How's your driving? We're asking about all of those things at the initial visit. If the patient is still working, some of our folks are, how are they doing at work? Are people at work starting to make comments? Are families and friends starting to make comments? And then we're also looking at other changes. So, Molly's going to go over the 10 warning signs of Alzheimer's disease, but there are some other dementias out there that can impact more like personality, demeanor, judgment, and problem solving. So we also want to ask about things like that. And then, of course, we're getting, how are they sleeping at night? Any mood changes that we should know about? Any family history of Alzheimer's disease or other dementias? Has it run through generation after generation? Any major head injuries, repeated concussions, repeated times where they lost consciousness, because we're really trying to get a full picture of the patient. My providers really like looking at brain imaging as well. So often if that's available, we really like to look at that. CT scans or MRIs, because that can show us some of the changes in the brain that can help along with the diagnosis. And then, like I said, any sort of labs, office notes from a primary care provider that can help fill in some of the other history as well, including other medical history. So depending on, you know, the complexity of the story, how willing people are to give information, how chatty a patient or family member is, this can take us anywhere, you know, if people really have it all together, maybe 5 minutes, but closer to like 20 minutes just to get all of this together so we can present it to the doctor. And like I said, at a new patient visit, often it's a nurse, myself, or one of the other social workers just gathering this information. So then after all of that, we would move on to a cognitive assessment. It's a paper and pencil assessment in our clinic. There are many different types out there. Some other primary care or specialty clinics might have their own versions of cognitive assessments. We use two in our clinic. One is called the Montreal Cognitive Assessment, or the MoCA, and one is called the Mini Mental State Exam, or I shorten it to the Mini. So if you hear me say MoCA or Mini, that's those two. And just in case people haven't had any experience with them, this is what they look like. I'm not going to go over every single question, but they're both cognitive assessments that look at different aspects of memory, attention, thinking, language. They're both scored out of 30 points. The one with the animals, which is on my left, I don't know if it's switched for you guys, but it's on my left with the animals. That's the Montreal Cognitive Assessment. That one is a little bit more complex. So we usually use it for folks who are earlier on in their progression, maybe even like a preclinical Alzheimer's disease, like a mild cognitive impairment, folks that are pretty independent where the memory loss is maybe there, but rather benign. If people are more progressed, or as we follow them throughout the clinic, we're more likely to switch to the Mini Mental State Exam, just because it tends to be a little bit simpler, and completing something like the MoCA when someone is in, you know, moderate stage Alzheimer's disease can just become really cumbersome and just disempowering for the patients. It's just not a fun experience to try to struggle through something like this. So we typically start with the MoCA if people come to us early enough, and then at some point transition to the Mini Mental State Exam. The MoCA can take about 10 minutes to complete, depending on how quickly somebody goes through it. The Mini's a little bit shorter, again, because it's simpler. Maybe that's 5 minutes or so. So there's just different questions on the MoCA. The top looks at visual spatial, some problem solving there with drawing the clock, some naming, some language. Can they look at these animals and tell me what those animals are? Do they have trouble doing that? Some memory tests, of course, pieces of attention. We had someone just yesterday come in, and the only points he had lost on the test were surrounding attention. And it just so happens that he also has a history of ADD or ADHD. So that kind of makes sense, because that was the difficulty he had always had. So we had diagnosed him with normal. He didn't have a cognitive impairment, but you know, we kind of expect to see that. So again, we look at, with these tests, you know, what questions are people getting right? What are they getting wrong? That sort of thing. All right. And then, so meanwhile, while myself or someone else in the clinic is doing the cognitive assessment with the patient, we also give the informant, the family member, friend, caregiver, whoever came with the patient to the appointment, a set of paperwork to fill out as well. So one of the things we give is called the 88. My providers really love it. It's very simple, but very sensitive. So it's just 8 questions, yes or no. Have you noticed a change in these 8 areas? They say a score of 2 or more. So 2 or more yeses is kind of suggestive of something cognitive going on. So we really like when primary care providers have this, and we always give it to our informants as well. The other paperwork, one looks at activities of daily living. So how independent is the patient coming in? Again, they're really early on in their disease progression, probably fairly independent, but as they progress, this is helpful for us to track. The one on the right, the neuropsychiatric inventory, looks at different symptoms or behaviors that can come up: delusions, hallucinations, anxiety, depression. Sometimes people don't feel comfortable saying it aloud in the visit, so it's helpful if they can mark it off here. Again, it allows us to track, you know, certain symptoms that are popping up with these patients and looking at what do we need to treat. And then finally, we use what's called the Clinical Dementia Rating Scale, or the CDR. We use, I like this one quite a bit. We borrowed it from some research studies, but basically family members go across for each of these categories and mark the box they think best describes their loved one. If they're in between two, they can put a mark right in between. And we'll kind of take this at the appointment and use it to talk to the families about staging. So if they put, a lot of X's in this one column, this mild dementia, my providers might take this form, go back to them and say, look, like you've marked your loved one in this mild dementia based on the history, based on the testing and the rest of this. We agree. We think that they also, we too think they have mild Alzheimer's disease, or we think you underscored based on how they're doing and functioning. Maybe they're more moderate, so we can use this to talk to families about different stages. And then if we have all those pieces together at the first visit, which I say happens quite a bit, which is very exciting for us, if we have all of those pieces and we're able to put it together, because not just one of those things is diagnostic. Like I said, it's a disease of exemption. It's really about putting all these different parts. We're often able to make a diagnosis at the first visit, which can really help with care planning, education, resource connection. If it's a really complicated case, or if not all the information is available, if they did not bring an informant, despite how many times we ask them to, then sometimes we need a follow-up. Maybe we need brain imaging, maybe we need additional testing just based on the symptoms. But oftentimes it's within the first visit, sometimes second or third, depending on the complexity of the case. And that's really important. What we really focus on here is trying to get people an early and accurate diagnosis. I know that's very important to the Alzheimer's Association too, because it's so helpful for the patients and the families. So in terms of some of the benefits of an early and accurate diagnosis for patients, we are catching this, in the mild cognitive impairment or early Alzheimer's disease stage. It provides them more of an opportunity to better understand the diagnosis and expectations. We often see in the moderate stage, people lose the ability to have insight into their condition. So it's very difficult to understand. So the family may finally know what's going on. And then we get the phone calls, can you just talk to my mom and tell her she's got Alzheimer's disease? And it's like, I could probably talk to her for 2.5 hours each and every day, but she might not remember it or really fully realize, what I'm saying when I say the doctor diagnosed her with Alzheimer's disease. So if we have that earlier on, it can be helpful for the patient to understand, maybe what is going on, why they're having some of these issues. It also allows for them to make the ability to make choices about treatment options, including access to clinical trials. I won't steal Molly's thunder about Trial Match. She'll probably mention that at some point, but I know here at our center, a lot of this, we have a couple studies going on, and they're mainly for people with mild cognitive impairment or early Alzheimer's disease. So that can be important too, if they wanted to take part in studies or look at different treatments. And again, also, it just gives more time to make future plans before cognition declines further. If they're working, how can we help them to exit gracefully from the workplace? Before something happens, before, a supervisor gets mad or colleagues get mad. We've had people come in because they've been fired, for not performing at the level that was expected of them, and they don't understand why. And then they have this disease, we feel bad. It would have been better if they had come earlier. They could understand it. They could exit gracefully from the workplace. Looking at financial and legal arrangements, making sure healthcare directives are put in place, and just long-term planning in general. And of course, it's beneficial for the care partners, the family members. It just helps them to have more opportunity to learn about the current and upcoming symptoms. We've had people come in who believe that their mother at 85 years old, who has never had a mental health diagnosis, has all of a sudden developed schizophrenia because they're hallucinating, they're paranoid, they're delusions, right? They hear that, they think, what we see on TV with schizophrenia. Does my mom, who has never had any sort of mental health diagnosis, have this now at 85? And then we can walk them through. Now it's Alzheimer's disease. We think she's in the moderate stage. These come up. These are the different ways that you can handle some of these behaviors. So we catch that earlier on. We get to educate families earlier in the disease before a crisis happens. What are some of the challenges that the patient might experience? How can the family be best there to support them? What can they expect? How can we plan for safety issues that may come up with disease progression? And again, just that future planning as well. So it's really important for us, again, to have that early and accurate diagnosis. And then just very briefly, that was all kind of one arm, the clinic side. Just a minute or two on the second arm. The Center of Excellence for Alzheimer's Disease as a community partner. So what we've been tasked with by New York State Department of Health is really providing outreach, education, training on Alzheimer's disease and other dementias for folks in the healthcare field. A lot of what we've been asked to do has been to target primary care providers, hospital systems, RNs, social workers in the healthcare field, all of that. But we try to talk to anyone in the health sphere who will listen to us talk about Alzheimer's disease and dementia. So again, just working closely with community partners, providing consultation services with when needed, us in the social work kind of department, the little one that we have, working with other community resources, on linkages to resources on disease information, and providing some of the education and training. So that's kind of said here. So it's really available to physicians, healthcare professionals, allied health professionals. We do a lot of work with students in some of the local colleges and universities. So again, anywhere where we can plug in, where some of our information might be valuable to folks, that's where we like to be. This is a list of some of the trainings that we have provided in the past. It is, all of those are included. They're developed, but not limited to by any means. We like to be very creative over here. And I can, when Molly gives you materials, Molly, I'm going to write a note to remind myself to give this to you to give to them. All right. And I have a slide for questions, but I think we're going to do those at the end either way. But thank you all.
Thank you so much. This was really helpful. Do folks have questions right now? Okay, I just had a couple of questions. I just wanted to know because, in the community-based organizations often, and here, as well, we're often dealing with people with a lot of challenges in terms of transportation, having that informant, et cetera. Is something like the AD8 available to be utilized out in the community? So that way, if they do get that score of 2 or more, we can kind of facilitate that conversation as well as the coordination of care?
Yeah, some of this can definitely be used. The only, because we've had this conversation internally on like, can we go out? Because like I do the cognitive assessments, I talk about administering the scales, and like, could we do like almost like free memory clinics? And some of the issues that we've run into in the past is if you're not able to provide that follow-up or that kind of like next step, if the family kind of marks like 8 out of 8 on the 88, and you're like, oh, you should get a follow-up. And then it's kind of left like that, but they're not actually given help. There's some, if we couldn't guarantee the follow-up, then we weren't able to kind of do these. So you can use it definitely, and again, if you're working with a family member or a family overall and just kind of asking, even if you don't use it formally, to have the family member fill out, to have it inform some of your discussion with a family member and say, look, like, it sounds like you have some concerns that there have been some changes that have been going on cognitively or with memory or with interest, just some of those different topics on the 88. Why don't you start by having a discussion with your primary care provider on it? Just to see, because again, then we want them to rule out. We've had a couple people come in too where it's just really severe depression. It's impacting their ability to kind of do their ADLs and function. And again, my docs are really good at weeding some of that out. But if the primary care can do it before even getting to us, that's even better, because then the patient can get help faster.
Great. And that's, I'm kind of alluding to is really the emphasis is on the early detections at the most help, and also in terms of ruling out. So it sounds like there's potential for free memory skills workshops in those agencies that have care coordination embedded. Is that right?
Say that again. I'm so sorry.
That there's potential for these free memory skills workshops if the organization has care coordination already embedded, so that they would be able to then assist with that next step?
Potentially, yeah. We've never gone down that route, but yeah. If it was linked, my guess, if it was linked to some sort of like clinic, like someone who had the clinical diagnostic skills to then take something like the 88 and say, okay, this is indicative of something going on. Now we've got the clinical diagnostic piece to say, okay, this is exactly what's going on. We've done the scans, the lab work, the cognitive testing, the history. It looks like Alzheimer's disease, or wait a minute, something came up. Your B12 is really low and that's impacting your memory, something else. If you had that clinical diagnostic piece available, then in my mind, something like that would be more appropriate.
Okay, last question, promise. Is there any common co-occurring disorders you see?
Actually, that's a great question. Yeah, so we see a lot of diabetes would be the first thing that comes to my mind. And diabetes and dementia are not good bedfellows at all. They can kind of exacerbate one another. The dementia comes, we stop kind of managing the diabetes as well. That makes some of the symptoms of the dementia worse, and it's just a vicious cycle. So we see that quite a bit. If that is on, again, that's important for us to know. So if that's on an active problem list from a primary care office, if that's a diagnosis, we're definitely looking at that. How are they managing their diabetes? Is it under control? Could that be contributing to anything that's going on? So that'd be a big one that comes right to the top of my head.
Great. Thank you so much. I really
Yeah.
appreciate it. And now we'll switch over to Molly.
Great. Thank you. Thanks so much, Natalie. That was really thorough, and always appreciate hearing about the services. And you'll notice during some of the presentation that I'm going to do, there's a little bit of overlap, and Natalie did a fantastic job of explaining some of those pieces. So I'll reference back to her presentation during that time. But I also just want to thank you so much, Carrie, for having us and organizing everything. We really appreciate everyone's time.
Happy to.
Great. So I'm just going to go ahead and share my screen. We were testing some things out when we first got started. So hopefully you all can see this. There we go. Perfect. So I'm going to just take a step back, and we're going to start from the basics here and talk a little bit more about the 10 warning signs of the disease. And we're also going to talk about the difference. I'm sorry. I just realized this didn't completely restart to the beginning. There we go. We're also just going to take a deeper dive into, oh, I see that there's, okay, that was just a chat. We're going to look at the difference between normal aging and problematic memory loss. So we do know that that sort of gets intertwined, and in society, we've sort of normalized forgetfulness. And after this presentation, I hope that everyone sort of has an understanding that forgetfulness or problematic memory loss is not a normal part of aging. While things do somewhat get slower when we age, it's not normal to have that forgetfulness. So it drives me nuts sometimes seeing like greeting cards in the store that sort of poke fun at forgetfulness, and we're sort of here today to debunk that myth about aging. We're also just going to talk about how to approach someone who is experiencing memory concerns. We definitely see that this is a huge barrier for family and friends to bring up to a loved one that's experiencing these signs and symptoms. And Natalie did a really good job of explaining, the next steps to getting a diagnosis and investigating the issue. But when I'm meeting with families all the time, the challenge is that individuals are just really scared to bring this up, and there's a lot of fear behind it. So I'm going to discuss a few ways to bring this up. And I should also note, I'm from the Alzheimer's Association of Northeastern New York, and we cover 17 counties. And we actually have field staff. We have program managers that are in each one of these counties. I help cover Albany County with my colleague, John Weaver, who's our program manager for Albany County. But we're able to actually sit with families and go through this type of conversation and rehearse it with them, give them some tips, and just give them some education about the disease so they feel like they're going into this conversation really well equipped and not feeling incredibly stressed or feeling like they can't approach their loved one. So I'll talk more about our services at the end, but that's really what we're here for. And all of our services are free in each one of our counties. We're also just going to talk about just briefly about the importance of early detection, which Natalie did a fantastic job of explaining, and the diagnostic process. So we'll go over that pretty quickly since Natalie touched on it, and the diagnostic process. And I'm going to spend a bit more time since we've talked about the diagnostic process. I'll focus more on our services that we have available besides the consultation that I just mentioned. So we're going to use the Garcia family. They are a fictitious family, but we use them as a really good example of what we see when we're meeting with families or friends or loved ones when the conversation is just getting started. And I should note, you're going to see up on the screen some video areas. The videos are getting cut off, so I'm just going to be talking over them today. So just disregard any sort of video prompt you see. You'll be hearing from me instead. So this family that we're going to get to know, the mother's name is Mary. She's 73 years old and she does live alone. She's always meticulously cared for her home. And what's troublesome is that her daughter actually recently noticed that laundry is piling up. The mail and newspapers are all over and they're scattered in her home. And that was not like Mary. She's always been a really neat and tidy person. And suddenly sort of these piles have been left and messes have been left. That is very different. So Lydia, her daughter that's on the left there in the photo, she's the oldest of the two daughters. She lives just a few miles away and she sees her mom daily. And then the daughter on the right is Patricia, and she actually lives in another state. And she does talk to her mom on a regular basis through the phone, but she doesn't get to see her mom that often in person. So one of the big things that Lydia noticed is that her mom's mess is popping up. So this is where she brings this up to her other sibling, who is a long distance caregiver. And as you can imagine, we see this often. And it doesn't always have to be a long distance caregiver. Sometimes it can be a family member or a friend that's just more involved in the person's life compared to maybe some other family or friends. And so they're sort of noticing this change first versus folks that aren't coming in as often. So, in this conversation, she's bringing up about the mess in the house, and the sister responds back and says, well, it's probably normal to be a little forgetful with age. And it's very unlike her, but it's probably normal. And so I just mentioned this before, but it isn't normal to be forgetful. And when I'm out in the community, oftentimes individuals, because there's a lot of stigma and fear with the disease, there's sort of this just real anxiety about potentially showing signs. And I definitely see this when I'm working with older adults in the community or older groups, where people will start to come up to me before my presentation has even started and say, sometimes I forget so-and-so's name, or I forget the date and it comes back to me, but I get really nervous that I forget it in that moment. And what we really want to tease out is that normal aging, that will happen. We unfortunately, getting my hair colored today, but I do have gray hairs. Everyone ages. This is a part of the physical process of aging. And with that, our brain does slow just a little bit, but not to the point where it's impacting your daily life. So I like to use a good benchmark where it's saying, if there's something that is impeding on your daily life, that's enough to be concerned and follow the steps to go and see Natalie. If it's something that comes to you later, or it's not really affecting your day-to-day life, so some of us have trouble finding words. That just happens, but you're able to substitute something in. It's not going to be the complete, ideal word that you wanted to use, but you're able to get your message across, and that's okay. So I guess the rule of thumb really is, if it comes to you later, if it's not impacting your daily life, it shouldn't be something that you're concerned about. But if it is something that is impacting your daily life due to memory loss, that's when we really want to take a closer look at that. So let's look a little bit deeper into what the difference is about from Alzheimer's disease and dementia, because that's always a good place to start. And Natalie, you did a fantastic job of describing, why it is really important to get a diagnosis so you can tease out those other types of dementias and see what the cause is. And so when we look at the word dementia, that's really an umbrella term, and there are several different types of dementia. Alzheimer's disease is the most common form of dementia. So unfortunately, in our society, they're sort of used one and the same. When I'm speaking to different groups, sometimes I hear so many different combinations, like dementia is the beginning and then it progresses to Alzheimer's disease. Dementia is the worst one. And Alzheimer's disease is a little bit not as bad. You hear these things, and it's just because there is this misunderstanding of dementia is that umbrella term. So a nice way that I like to explain it too is we have come a long way with cancer and cancer research. And when we think of someone that's come up to us or has told us a story about someone being recently diagnosed with cancer, I don't know about all of you, but the next question I'm thinking in my mind is, well, where is the cancer? What type of cancer is it? It's sort of normal to say where the cancer is. And that's really where we have to progress with dementia. When we hear someone saying, my mom was just diagnosed with dementia, the follow-up question should be, what type of dementia are we dealing with? So a majority of folks that are in this dementia category are going to fall under the Alzheimer's disease diagnosis. So that's, again, the most common form of dementia. And Alzheimer's disease is progressive. We see that usually people are living with the disease between 8 and 10 years, but it really is a span from 3 to 20. Everyone is really different with the disease process. And when we're looking at a diagnosis, we want to look at the symptoms and evaluate, like Natalie had shown, with all the tools, and also using family and friends to get some information to identify, are these symptoms related to Alzheimer's disease, or could this actually be something else? Could it be vascular dementia? Could it be Lewy body disease? Could it be Parkinson's disease dementia? And all of those different types of dementia have some of their own subsets of symptoms that are different. So they fall under that umbrella, but they're just a little bit different. And I can address this now. I know it's later on in my presentation. It is really helpful for care partners to know what type of dementia that they're dealing with, because they all have their own symptoms, and you want to, as a care partner, know what you're dealing with, be educated about how this disease progresses or that specific type of dementia presents. We've worked with families, obviously, through all different types of dementia. We're called the Alzheimer's Association, but we really support any and everyone that's going through any type of dementia. And there are many different organizations like foundations, other associations that are specific to specific types of dementia. And we work with them really closely. We refer our families to them. But the Alzheimer's Association, we're really a pioneer in communities, and we have so many programs that are available locally that some other foundations aren't able to provide on a local level. So we always tailor our programs to reach that wide net. I've had people in my early stage programming that have different types of dementia. They're not Alzheimer's disease, and they're still able to relate to the content, and their care partners are very well. It's just giving that additional support and following up with specific dementia, their specific type of dementia, and that information. So let's move on now to the 10 warning signs of the disease. I'm just going to go through each one and give an example. And you'll see up on the slide, they do a really good, I love how they highlight what's normal age-related change. I always think that's such a good way to just remind folks that, yeah, there are some things that we do in life that are just a part of life. I actually worked a professor that I was, when I was in grad school, came up to me and said, I'm so concerned. I feel like I always forget things, Molly. Like, I know you work for the Alzheimer's Association, and I feel like every day I'm forgetting something. And when I talked to her a little bit more, she realized that she is overloaded on her plate. And sometimes that just happens when you're overworked, burnt out, and you're doing many different things all at the same time. And so I really like how they highlight these different areas to just sort of check individuals and say, this is the difference. So the first one is memory loss that disrupts daily life. So a really good example of this, and I should note, I'm affected by this disease personally. My grandmother was recently diagnosed. I've called upon Natalie many a times to talk about this. And when she was going through this process, we noticed that she was like the type of person that would always send a birthday card like 3 days prior, and then she would call on your birthday to say happy birthday, but hey, did you get the card? And she started forgetting everyone's birthdays. And there was really no recollection. Sometimes I would call on my birthday to be like, hey, Nana, it's my birthday. And of course she would, be like, oh, yes, that's right. And she would sort of fall in line socially, but that was not like her. That was not like her at all. It still isn't. And at this point, like that is completely, as she's progressed through the disease, she doesn't really associate time of year at all. And we'll talk more about that. But working with families, we also see that individuals will just ask the same information over and over. You might tell them, hey, an appointment is tomorrow, and they're not understanding why it isn't right now in that moment. And they might just keep asking when that appointment is. We also see folks that, yes, we all use memory aids. I think all of us have something that gets us to where we have to be. But this is beyond this. I've worked with individuals that have literally put Post-it notes that say, close the door, lock the door, turn the oven off, turn water off when using sink. So these are things that are over relying on these notes, and even family members that are calling and checking in and saying, hey, did you turn the shower off when you got out today? Or did you turn the oven off? Those types of memory aids are definitely a sign that something could be a concern. Number 2 is challenges in planning or solving problems. So we do see that folks that are going through this sign, something that used to take them an hour to do, like getting ready for the day, can take 3-4 hours. And you can prep them and remind them, but everything that they're doing might take longer with their daily routine. And I also see when I'm working with families that one of the best example I can give when it comes to this sign is families that notice that their loved one who's always been on time with their bills, paid them, wrote out checks, they started to see that their loved one wasn't keeping up with it, was getting past due notices. I even worked with a family where they saw many different copies of checks where they could put pieces together that their loved one wasn't remembering how to write out a check in order to actually pay for the bill. Number 3 is difficulty completing familiar tasks. So this is where we see folks that might have trouble with, the example that's on the screen, organizing a grocery list. And if you think about how many pieces are involved with organizing a grocery list, it's taking inventory of what you do and don't have. It's traveling to the store. It's navigating the store, seeing where things are, picking out things. It really relies on memory and navigation skills and planning, and that's all disrupted by Alzheimer's disease. All those areas are disrupted. It's not just memory loss, it's the planning, the solving problems. So folks that are showing this sign, they're just not able to do those daily tasks like they used to be able to do, or play their favorite game and remember all the pieces. I was in long-term care for a long time, and one thing that I noticed from a gentleman I was working with, he said, I am a master bridge player and I started to forget how to play bridge, and I've been playing for 40 years. So for him, that was like a big change. Confusion with time or place. So I mentioned this a little bit with my personal story here, but this is where folks will really lose track of time, passages of time, dates. So not understanding if an appointment is tomorrow, that it's tomorrow, it's not in that moment. This is where individuals can get lost too. Just not understanding where they are, how they got there, and that passage of time. Number 5 is trouble understanding visual images and spatial relationships. So this is where we see some individuals might have some increased falls because they're having trouble with their balance. They might really be a fall risk because of this sign. We also see that folks are having trouble with reading. So I work with families, and they will sometimes indicate that their loved one would always open up the paper first thing in the morning, and suddenly it's like they open it up and they put it down and it's just sitting there. It's not even really being touched. Reading is really hard when someone is going through this disease because it's taking in what you see on that page, interpreting it, and because of this sign, reading can be a real difficulty. And for many family members, that's really another jolting moment when they notice that someone's an avid reader that's suddenly just not partaking in that type of daily newspaper or their magazines or anything, or their novels, books. And then the last example here has to do with driving. And I'm sure Natalie can agree, this is a big loaded area here with driving. It's a tricky one. But this is really why driving is dangerous with the disease, because folks aren't able to really judge distance. They think that things could be farther away than they really are due to the disease process. Contrast is affected. And that's really where we see these fender benders come up for individuals that are showing signs of the disease, and why it is dangerous to drive with the disease, because of how the spatial relationships are affected. Number 6 is new words and, new problems. I just had a problem with words myself, but new problems with words in speaking or writing. So this kind of has to do too, I was mentioning reading, but this also has to do with writing too. It sort of goes along the same lines, but when it comes to a conversation, if you've ever been around somebody that's going through the disease, you might have experienced this where the individual is repeating the same story over and over. My grandmother tends to want to seem social, and she's a really smart person. And she wants to contribute in the conversation. And I've noticed lately she's repeating the stories I'm telling. So I was telling a story about how I went out to dinner with my husband, and during Mother's Day, my grandmother repeated the same story to my dad, just so she could sort of fill in the gap socially, and she just heard it, so she applied it to herself, which was interesting to sort of hear that mirror effect there. And then individuals will struggle with vocabulary. So we see that some folks might use a word that just doesn't really make any sense in a sentence at all, and you're trying to piece it together. Some people use a word that sounds similar, but it's not the perfect one, but you piece it together. Overall, it's just pretty difficult to go through the conversation with them. And that's really how this sign presents itself when it comes to communicating. And I will say, once a person is diagnosed officially, I think this is probably the biggest area that we concentrate on when we're talking with families, is how to communicate effectively, because it is so frustrating for the person living with the disease and for the care partner, the family, friend, to be able to effectively communicate. And we do have programs on that as well. We do hour-long programs on effective communication skills as well, which is really helpful. Number 7 is misplacing things and losing the ability to retrace steps. So this is, it says it in the actual sign, but folks will try to put things in a place that's safe to them in the moment. So if something is enclosed or available and it seems safe, they might put it in there in that moment thinking that it is safe, but it doesn't make sense. And so you may have heard of like the keys in the refrigerator. It doesn't make sense, but in a way it does. If you put the hat on of somebody that's going through memory loss, it's an enclosed space, it has a shelf, it's safe. So that's how things sort of get lost in people's homes, is they're putting things in areas that don't really make sense. And then they're not able to retrace their steps to go and find those objects. And then we also see that with this sign, this is where individuals start to become accusatory. So they will accuse their loved ones of moving something on them. They might even accuse their loved ones of stealing things. I've worked with many families that are very heartbroken because their mother or father is accusing them of stealing massive amounts of money. And of course, they wouldn't do that. But with the disease process, when they don't understand where they put things or where things are, that's where that accusatory behavior comes into play. Number 8 is decreased or poor judgment. So we do see with this sign that it does usually pertain to money. So people are giving away money to, reputable charities, but massive amounts. They're giving money away to scammers. They're giving money away to family that doesn't really want the money, but they keep saying to take it. There's even some family members that I've worked with families that they didn't have the best intentions, and people were, with their poor judgment, giving money away to family, friends, etc. So we do see that this does hit financially usually, but I've also seen it in situations where a person who's either had family or friends or professional service come and repair the roof or do the lawn mowing or the shoveling, suddenly they're out there in the disease process. They're trying to fix the roof. They're trying to shovel all these areas that they haven't in years because physically they're not able to. And suddenly with this sign here, they're out there with poor judgment. And this is also where we see individuals having issues with grooming themselves, whether it's changing their clothes on a daily basis. They might repeat and wear the same things, and that's not like them, or they're just not bathing like they usually would. And as the disease progresses, we do see that this is a part of the disease process where individuals will not understand that they need to groom and make these decisions for themselves, and that's where care partners really step in and help with the grooming piece. Number 9 is withdrawal from work or social activities. So Natalie used a fantastic example of how it's really helpful to get someone in to get an early diagnosis. So if they are still working, we want to make sure that we are addressing their needs at work, because it can become a really difficult situation in the workplace. And we've worked with families that are going through that, where their loved one is showing signs and they're not able to do a lot of the tasks that they were able to do at work any longer. And that can be very tricky. We also see that folks that are exhibiting this sign, just things that they've always loved to do, they're not showing up and doing them for really no reason at all. They might not be able to explain. Using my grandmother again, she worked in a church as a secretary, and so as you can imagine, she would go to church like 3 times a week. And suddenly when we were asking her to come with us, she didn't want to go at all. And that was not like her. But when I ended up asking her some questions, she's aware of her disease process. She knew that she was exhibiting some memory loss. And she told me, it's really embarrassing to not know people's names that I've known for 30 years. And I understood in that moment why that can happen, where folks are just withdrawing from these things that they've always loved. And then number 10 is changes in mood and personality. So this is really where we see folks get suspicious, accusatory, like I mentioned in the previous sign. Maybe they're depressed or fearful. I think a really, really common example of this is just not being able to cope with small changes, getting very upset by a small change. So with my grandmother, when I brought her to Panera, when it changed over to the kiosks, how they had that on the side, that really upset her. That was like a reaction to that was beyond just somebody saying like, oh, that's interesting, they have kiosks now to make it faster. It was, why would they do that? It's too confusing. I don't like it. It's not the same way. And she got teary-eyed because it was so overwhelming. So there's so many other examples of this, but it's just something that's small that the individual is just not able to cope with because it's changing their routine. So they might have a reaction to that. So those are the 10 warning signs for you all to know. I will say that when it comes to these warning signs, one of the questions that we do get asked often is, do you have to have all 10 to actually go and see Natalie or the CAD? So no, the answer is you don't have to have all 10. It's really important that if there are a couple that are concerning, that are impacting daily life, then it's worth it to really make that next step, to do that next step and see what's going on. But you don't have to have all 10 in order to go. And I think for some families that I've worked with, it's tricky because when they're starting to see these signs, it's, you know, their loved one can come in and out of it. So in the morning, they might have a really good morning and they're like, see, she's fine. And then later on in the day, things tend to sort of start up again. And that can be a yo-yo and really confusing. We also know with Alzheimer's disease in particular, folks will have initially really bad short-term memory. Like the short-term memory is probably the first thing that people start to see. But with the long-term memory, it's intact and they're able to describe memories from a while ago. But if you ask them what they had for breakfast, they would have no idea. That can be confusing to a family. I've talked to families where they're like, well, you know, they are able to recall some things in the past, so I wasn't sure if that was concerning or not. And you can see how the short-term memory does impact daily life if you're not able to retain recently learned information. So that's enough to really know that you have to take the next steps. So we're going to go back to the Garcia family. And again, this is sort of like I was discussing when families start to come together and talk about this. When you're first learning about the signs, I just talked about it, but you know, you might question yourself and say it's only a couple, or it's during different times of day. It can be a little confusing, but the answer is if it's impacting their daily life, it's really worth getting further evaluated. So Natalie touched on this section, but just to reiterate, it is really important for individuals to get a diagnosis and to focus on that early detection, because we know and we have many programs for early stage constituents, so folks that are living with the disease in the early stages. And when we're talking to them, we want to learn what they prefer. You know, what do you prefer for your care? What are the decisions that you want to make? And so the earlier you're able to diagnose this disease, the ability to actually talk through preferences and talk through these things is so important, and to be able to plan. I've worked with families where they were able to have this ability and talk to their loved one about preferences, and they said, I'm so glad I brought some of this stuff up. It was really hard, but I can't imagine being the one that had to actually make a decision that's so big without their input, and that affects them. So it really does affect the care partner. And also it ultimately affects the person living with the disease, because we want to honor their preferences and do what's best for them. And by doing that, we can talk to them about it. Now, on the flip side, I do want to bring up another component, and Natalie touched on this. So, you know, my grandmother, I mentioned, she has awareness of her disease process. Not so much now, I would say more in the earlier stages, she was able to sort of talk through these things. But for many people that we do meet with through their disease process, their loved one's disease process, they get very upset if you are to bring up this to them. If you were to say, I'm concerned about your memory, or we think something's going on, they might say, I'm fine. I don't know what you're talking about. I'm good. I'm better than I've ever been. I'm clearer than I've ever been. And what we know is with the disease process, that can happen, where individuals are just not aware of what's going on with some of the changes. And you, as a friend, as a family member, you might be the one that's seeing these changes, and not the person. Or maybe you and the family are the first one to sort of bring this to the table, which can always be tough. So what do you do in that situation? This is a a really good tool that we have. And I actually, Carrie, I'll make sure to send, I actually have a worksheet of this where you can fill it in. But when we're talking with families about getting their loved one to get a diagnosis, which honestly happens more than folks coming to us with the diagnosis. I want to reiterate that we're here for anyone that's going through the signs and symptoms of the disease. There isn't a diagnosis that has to be associated in order to receive our services. We are a majority of the time meeting with families that are just starting to sort of tune in and know that there's a problem and what do we do next. So this is what we walk family members through. And Natalie touched on this a little bit, but this is where you might utilize a log, and the tool that you had, Natalie, is really helpful as well. But this is where we see, or we tell families, write a log, jot down the things that you're seeing, time of day, what it is, how often, write it down, because it's good to validate that for yourself, and it can also be used in the future, as Natalie was pointing out with some of the tools that they have at the CAD. You want to evaluate what else is going on, which Natalie talked about. It could be something with lifestyle, our diabetes, is their diabetes under control? Is that maybe contributing to some of similar symptoms? Has there been a really traumatic event like a death in the family recently where an individual is just not acting like themselves? We do see that, especially with older adults that have had a life partner for decades. When someone passes, it can be very traumatic and lots of role reversals and tricky things, and folks might they might exhibit things in a concerning way, and you want to just take that into account. You're already doing this today, but learn the signs and symptoms of the disease. Has anyone else noticed the changes? So yes, you might be the first one that's noticing these things, but take inventory of other people around you. I actually love to tell families, take that long distance caregiver, that brother, sister, niece, nephew, whoever they might be, friend. If they're not around all the time and they come in to visit, use their perspective as well. Sometimes we see that the individuals that are with loved ones every day or frequently, sometimes they miss things because they're compensating for their loved one, whereas someone that's not always with them can sort of see these changes in a different light. And then the next step is really having the conversation. And you really have to decide who's the key player. So sometimes when I'm working with families, the person that is with them all day, every day, might be the one that is getting in a lot of, sort of arguments with their loved one. They might have that difficulty. I always say the one that is closest to the person is usually the one that's sort of getting a lot of the resistance to things. And that's where you could always use a family member. I sometimes, for family units, I like to say like the golden child of the group that sort of can deliver things in a different way, in a different light. They can say anything and do and say anything, and maybe the individual will take it in a little bit better. So maybe use that person that's outside of the everyday to say, we are concerned about your memory. Or we noticed some things have changed for you. And this also goes with picking the right time of day for the individual. I mentioned how this fluctuates for people with the disease. So you probably want to avoid having this conversation or bringing this up later in the evening if your loved one tends to have issues towards that time, and it's focusing on the right and the best time of day for them. And then this is really where we come into play. We can help you with things to say. We definitely tell families that it's not always in your best interest to come out and out of the gate pretty hard with, we're concerned you have Alzheimer's disease. That might turn the person off. It might make them defensive. So there's different phrases you can use that can still mean similar things, but it's a little bit more gentle. I like to use it gingerly, using something gingerly that will get them to a better place, that will motivate them to want to see what's going on. So even asking them like, how have you been feeling lately? You haven't seemed like yourself, or I've noticed some changes in you, and have you noticed this? Are you worried? And you can even use specific examples from your log that you use and say, because I noticed some of these things happened, and I can go through them with you. So that's sometimes a way to approach it as well. Natalie also touched on this. Please, if there's a way to get someone to go to the doctor with the individual to go to the diagnosis, that's imperative. We need that feedback from the care partner. And it's also, I know with my grandmother, my dad had sent her to the primary care, and he was like, go let them know what's going on with you. And when she left, she was like, everything's great. Everything went really well. I'm doing really well. And that's actually not what happened. So her interpretation of that first conversation was very off. And sometimes you may find that the individual is really resistant and is struggling, and it makes them really upset. Maybe take a time out and come back to it. And that's sometimes what we'll counsel families on is, okay, you've tried it, you saw some pieces that worked, some pieces that didn't. Let's start over again, because with memory loss, there is that ability to start over again at times, which can be a positive thing if you look at it that way. And then reach out to support. So I'm going to talk more about our services, and Natalie talked more about her services and the specialists. There are other specialists available. We do have lists of all the specialists in all 17 of our counties that are specialists in diagnosing dementia. So of course the CIAD is a absolutely wonderful place, and they do a fantastic job. If folks are outside of the capital district and are far away, we have resources in those counties as well. Oops. Sorry about that. So I have a sheet that you can actually utilize with some blank areas. If you ever wanted to get a copy of that, I'll actually send it to you, Carrie, so folks can have it. And I'm just going to skip over these pieces because they're a little redundant from Natalie's presentation. But when it comes to, I guess I'll ask the audience to see if we're all still here. There is currently no way to diagnose Alzheimer's disease, true or false? We asked this question because there is some misinformation out there about the diagnostic process. Does anyone want to chat it in or unmute themselves, true or false? Well, I'm going to go ahead and answer it for everyone. It's false. The reason why I bring this up is that there is a common theme out there during presentations that I've done where folks have brought up, well, I thought you had to have an autopsy in order to actually get an accurate diagnosis. And with a high degree of certainty, we know that we have tools and evaluations like Natalie reviewed that are accurate. And yes, there are some tricky cases, but they are very accurate and able to diagnose individuals, as you can see through her thorough tools that she showed. And we also just wanted to show that for some individuals, their assessment might look different. There might be all of these categories checked off, or some of them. And I know that Natalie sort of touched on this process, but it is a thorough process is what we really want to highlight. It's not a quick assessment. It's very thorough. And that's really what we need folks to do in order to figure out what's going on. And Natalie also touched on how sometimes, individuals can have symptoms of what looks like dementia, but it could be something else that we're dealing with. Sometimes that is actually the way too that I work with families and say, it might be worth your time to just rule it out and see. You never know. Like, it is worth it to see if something else is contributing that's treatable. and the dementia-like symptoms can subside. So at this point, I'm just going to go over our services so we just have time for any questions. And I thank you for your patience with the videos. I had to go through a lot of slides there, so I apologize. So what that slide was going to represent, although you couldn't hear it, is that we are a national organization. So what is really helpful is that a program that is seen like this, the 10 warning signs in Albany, a family can see in Kansas or California. So it's pretty uniform, and it's helpful for those long distance caregivers, and for families and friends to be on the same page about the education that we provide. This is also another really helpful resource. We have our 24/7 helpline. So yes, we have our local office, and we have several program managers that are there in the field locally, answering questions. You can call them directly. You can get that local information that you need. But we know that after hours, this disease does not stop. In fact, for many families, that's when things are just getting started with some behavioral issues, with just tricky situations. So the 24/7 helpline is available. There is a social worker that's on the line as well at our helpline, if needed for more complicated cases. And I should note that every single call that comes through the helpline, we get a report of the next business day from our local area. So every single one of our program managers every week is calling every family to check in on a local level and say, hey, I saw that you called and you had this question. It could be big, it could be small. We follow up and say, what do you need? I'm John from Albany. I'm Megan from Schenectady. Is there anything else that we can do? We also have our online resources, which is, there's a vast amount of resources on our website. This program that I'm doing, you can actually, we offer this virtually locally, and we will be getting back into person as well. We'll be doing some hybrid, online and in person. But if you can't make a specific time, or a family can't make a specific time, on our website, we have pre-recorded presentations as well. So if somebody can't watch something until 11 o'clock at night, they can go right on and watch this as well. There's driving resources. There are early stage, so folks that have the disease, if they want to look at information that's tailored for them, and in the being able to read something that's not caregiver or care partner focused, that's on there. And then in terms of our local options, I mentioned our education programs that we offer. We're always looking to partner with other organizations to offer these types of awareness programs. Or if you are working directly with care partners, we have several different types of caregiver ed, care partner ed programs, like communication and dealing with behaviors and how to handle driving. So we can do all of that with our staff. We have the care consultation model where you can call us locally and we'll meet with a person one-on-one. We're typically meeting with care partners in this situation to get them the support that they need. But we also have met with individuals that are nervous about their own memory or some of the concerns that they're having, and we'll meet with them directly. And in some cases, we have met with care partners and the person who's showing some signs to all be on the same page, and even multiple family members. We can do that as well. We can have a family consultation, and this is all free. Our support groups are vast. We have many. We've been running them through Zoom and the phone, but we are slowly getting our support groups back into person. We have a couple in Albany that are going back into person soon. And those are ideally for care partners. We ask for those care partner support groups that we don't have folks living with the disease attend, because we want to be able to provide that emotional support to the care partner. But we also do have an early stage support group for individuals that are living with the disease. They can meet other people going through it as well, and it's their own support group. So we have various different types of support groups between a millennial support group for younger caregivers for that sandwich generation as well, to a support group for folks that are living in a facility. We have all of that, and I'll share that with you, Carrie, as well as a resource in the to send out.
That'd be great. Thank you.
Yep. And I know we are wrapping up. I did want to just mention that Natalie had mentioned we have a few services in terms of like volunteering and advocacy. We're always looking for volunteers to do support groups, to do education, and advocates as well. But I also just wanted to highlight our trial match program. So this is a really amazing program where you can actually go on our website up, that's up on the screen, and you can make a profile, and you can actually see which clinical studies are going on in your community by zip code. And also, we're always looking for healthy folks to also join Trial Match, because we want to get baseline data that we can use for these clinical studies. So I signed up, and they'll send like a brain game type of thing for me to do, and they compile that data. So if you're ever interested in being a healthy participant, we're always looking for those individuals. But if you ever just want to see what's going on in our area with clinical studies and clinical trials, this is an amazing resource. And we actually have a lot in the Capital District. We have a hub of clinical studies that are going on in our community, which is fantastic. And so with that, I will end my Oh, I'm 10 minutes early. That rarely happens. So I'm just going to stop sharing my screen so I can see you all. Where's it? Okay. There we go. All right. So does anyone have any questions or comments? Anything I can provide?
I just want to thank you so much for sharing your personal story and also the wonderful tools and tips that both provided, and myth busting too. I think it's really common, what you said about people saying, oh, it's just, she's getting older, and
Right.
kind of, yeah. And then you can miss that early detection opportunity, as well as the information about this being a lengthy process for diagnosis, so that kind of is telling me that if I bring my loved one in and they get a quick diagnosis of Alzheimer's, that maybe I should go for a second opinion, because there wasn't all of these in-depth tests. Do you
Yeah.
see a typical age of onset?
Yeah, so we actually, a majority of folks that are going through the disease are in a category of 65 years of age and older. It's later onset. There is a smaller, more rare group of folks that get the disease 65 years of age and younger, and that's called younger onset. And so we do see that a majority of folks are in that later onset category. It is an age-related disease. So I should say that the risk factors, our number one risk factor is age. So it is an age-related disease.
Yeah, one of my providers estimates that he thinks the average age that comes into our clinic is between 72 and 75.
Very helpful. Thank you. And that's interesting also about the early onset as well.
And we do have resources locally. We do have folks that are diagnosed with that younger onset category, it's very difficult. I've worked with individuals that are in their 50s, and it is really heartbreaking because they are still working, and they are also, concerned about letting their children know, and it's very complicated. And we do have support services for those individuals. We actually have a younger onset support group that meets regularly, and they've all become very close. So we do have that resource as well. We work with like the CIAD and our other partners when we're seeing these trends of individuals that have specific needs. We really try to create some type of support group or support service around that unique situation. It's really important.
Does anybody else have any other questions or maybe around training or supports by any chance? I just want to thank you both so much. This has been so informative. It's great to know that there's such a wealth of opportunity for tools, for support services, for diagnostics, testing, et cetera, right here in our community, but also that we could refer people to your organization and probably also to CEAD, right? If they're out of the area to another organization. That's also great to know. I look forward to receiving all those wonderful tools that you shared from both of you, and then I'll send that out to the group. Thank you all for taking time out of your day, and if something occurs to you afterwards, please reach out and send me an email or phone call. Either one is fine. And if there's nothing else, then I wish you all a great afternoon, and I look forward to seeing you all again. Thank you.
Thank you, Carrie.
Thank
Thanks so
you.
much for putting this together. We appreciate it. Thanks to all of you. We appreciate your time. We're here if you need us.
Thank you. Thank you so much. Take care, everyone.
Bye-bye.
Bye.